Dr. Huang has been with us 6 months ago, and he gave a great lecture, and I'm excited about hearing what he has to say. He's from Renton, Washington, practices with Proliance Orthopedic Associates, and he's a member of the American Academy of Orthopedic Surgeons. So welcome, Dr. Huang.
Thanks. Thank you all, and I will not be offended by the postprandial tendency to nap. Unfortunately, I find myself doing that sometimes in clinic. It's very hard when you're talking to a patient about their knee arthritis and my eyes are blinking and thinking I wish I had some coffee. So don't worry, I get it. We're all busy, but I hope to keep you entertained and informed and educate a little bit as well. I came from the University of Washington residency program, finished an amazing 21 years ago. I can't believe it. Yeah, I finished when I was 16, so that's why I look so young, right? Young at heart. So we'll kick off. First, we're going to talk about just orthopedic exam pearls or principles that you can use in any joint except the spine. I'll use that as a caveat. I don't see spine problems unless it's unintentional and there's a scheduling mishap. So none of this really applies to the spine that much, but any extremity exam, upper, lower extremity, should work pretty well, these principles. And then we'll dive into a little bit of a review of the knee. The knee is pretty extensive in terms of the number of diagnoses and problems that you will have to consider when treating knee problems. So we won't be able to get to everything, but at least I'll try to give you an overview of some of the key things that you're likely to see more often. And hopefully some of this is valuable for you all who are taking recertification exams as well. So to kick it off, the exam by itself, not so helpful. So obviously the history is really key. The benefit of the history is if you have a good history, you kind of know what you're going to be looking for and what your top 3 possibilities are, so you have a better idea of how you should focus. So there's obviously 2 really broad categories if you're seeing a person with a joint problem or orthopedic pain of some sort. Is this trauma or not? So that's kind of the first fork in the road. So trauma, fractures, dislocations, torn soft tissue structures, etc. And then there's the atraumatic conditions, something due to inflammation. You went out and raked the yard for 8 hours first thing in the spring and you hadn't done any of that activity for a while and your shoulder's sore because of it. The repetitive stress, I work in a factory, I do this over and over and over 1,000 times a day, and I got this problem, that problem. Overloading, I'm training for this marathon and I've been trying to up my mileage and I got this mid-tibia pain, blah, 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 so stress fracture. So definitely the history is a real key factor, and even though we are technicians as orthopedic surgeons and we only really want to fix broken things, we got to always remember in the back of our minds before we get to fixing people's problems, we also got to make sure we're doing the right thing and examining them, taking a good history, and have the right diagnosis. Soft tissue degeneration. So this is kind of a variant of overloading, but if somebody's been a overhead laborer all their life, then there may be more chance of having rotator cuff degeneration, etc. So that's the next bullet point on atraumatic. And then finally, degeneration of cartilage. I was a runner for years and I've been a little bit on the heavier side and I've been having 5 years of knee pain and my family has a positive history for arthritis of the knees. So again, you can kind of get an idea, probably not going to be an acute ACL tear in that situation that I just described in the absence of trauma. So arthritis, DJD, we use the terms interchangeably, degenerative joint disease, obviously different than an inflammatory arthritis like rheumatoid or psoriatic arthritis. And then special considerations to each location. So for example, thumb pain close to the wrist, de Quervain's, veins, right? So you just have to think about what body part you're thinking of and are there unique things that you'll get a tendon trapped in a sheath and inflamed at de Quervain's veins in that zone, but you don't really get the patellar tendon trapped in a sheath and inflamed due to that similar problem. You can get patellar tendonitis, but it's a different animal. So for me, Somebody taught me this long time ago. I don't even remember who did, but it was probably when I was a med student still. The 5 S's. So span, smoothness, stability, and strength. And then the 5th is special. Again, that we just said, special to that joint or that body part. So to go through this, span, range of motion or span, you think about active, what the patient can achieve on their own versus passive, what you can achieve if you push them a little harder. A great example of the difference between active and passive is active motion at a knee. Let's say you have a quad tendon rupture and the person fell 3 days ago and they just can't get their leg straight. But I can straighten it if I use my other leg, or if I set it up and somebody holds it, it can go straight. So passively, it's got full motion probably, or near full motion. But actively, they can't extend their knee against gravity because their quad tendon's ruptured. So that's one of the examples of when active and passive motion may not equal each other. Every joint's different, so I'm just going to run through some of the big joints because I'm not a little joint kind of person. I tell people for hand and foot problems, little bones belong to somebody else, not me. Shoulder. So in the shoulder, you test forward elevation, which is just also known as flexion, which is in front of you. Abduction is out to the side. External rotation, you can test it both at the side and in abduction. Things you probably don't have to worry about too much. You just want to generally get a sense, can they externally rotate or not? And then internally rotate, we call the scarecrow position like this, or internal rotation up the back, how high can they go with their hand? And you're looking for symmetry. It's the beauty of it. That's why most of us orthopedics are simple-minded people. There's another side we can compare to, except for the spine again, but left shoulder, right, right? Assuming they have a normal other side, you can compare and get a good idea. So that's the shoulder, but in the elbow, it's a little different. Flexion, extension, those are easy, right? Flex and straighten it, extend, but pronation, supination. So pronation, supination, you hold the arms at the elbow and your elbows are by your side. How high can you do supination? Hold the bowl of soup, remember? So usually you can get close to 90 degrees, and then pronation, maybe 80 some. So that's a unique pronation, supination, unique to the elbow. Hip, there's flexion, extension, adduction, abduction, pretty straightforward. And then I say almost all other joints, simply flexion, extension, the knee, finger joints, right? In the ankle, you have inversion, eversion, some others that are unique, but in general, flexion, extension is the base starting point. Smooth. So is it smooth or not smooth? So if it's not smooth, then you'll notice crepitus. Sometimes the crepitus to us as orthopedic surgeons just means some kind of click or pop or noise associated with a joint moving. You can also get grinding or squeaking. Literally, it'll grind or squeak. And so in the shoulder, when you notice crepitus with active motion, not perfect example or guarantee, but sometimes you see that with glenohumeral arthritis. So not talking about AC joint arthritis, but truly glenohumeral arthritis. Literally, you can elicit like a squeak. It's pretty unique. Next, if you notice it more with passive motion sometimes, again, this is the shoulder, you may notice the crepitus with passive motion, and that sometimes is a little bit more indicative of a bursitis, tendinitis problem. And then there are joints that will have noise, and it's totally normal, or it can be totally normal. So don't always think of noise as an indicator of something that's problematic. So scapulothoracic and patellofemoral crepitus, extremely common. Do not automatically, that assumes, or reassure patients it doesn't automatically assume major pathology. Yes, it could mean there's some, in the patellofemoral compartment, some cartilage wear. Chondromalacia, the word we like to use most often, indicates some inflammation, synovitis, but it does not automatically mean we're going to have to go operate. If I operated on all the people who had crepitus at their joints, I would not even be here today because I'd be operating so much, because that's something we see all the time. So don't mistake lack of smoothness for the need to get an MRI or the need to refer to a surgeon necessarily. It's that whole principle. Does it cause pain? Does it cause weakness? Does it cause swelling? If not, it's asymptomatic. Let the person live with it. Now we'll go to stability. As you can see, there's a common theme. I'll kind of talk about the shoulder because I kind of modified this from the shoulder. But I'll talk about how it applies to other joints as well. So for this shoulder, far more common to have anterior compared to posterior instability. You think about the shoulder joint, it's a big ball on a small socket, and the socket is very shallow. So I tell people it's like a big ball on a small tee, like a golf ball on a golf tee. So inherently, there's going to be some instability when you have such a mismatch. Mother Nature gave us a labrum. So the labrum at the glenoid, at the socket, makes the socket a little deeper and a little bit bigger. And so it's sort of like a suction cup effect, but it's still a mismatch even if you take into consideration the size of the labrum. So the shoulder, by virtue of having such amazing range of motion, like no other joint in our body, also has inherent instability. It's a trade-off. So anterior, there's the tear that occurs down low called a Bankart lesion. People might have heard about that if you remember it. It's a tear of the labrum and the capsule away from the glenoid bone. And what that leads to is essentially, if you play golf, a tee that has been chipped. So you can get the ball to stay, but if there's just a little bit of a gust of wind or if somebody stomps their foot, the ball will fall off the tee in that instance when the tee is chipped. So that's what happens in the shoulder. You get a labral tear, or Bankart lesion is another name for it. And so that's the most common direction of instability. So the apprehension test means you hold their arm up in this position and you really try to externally rotate them passively and they will feel like their shoulder is going to pop out. It's not pain, it is, I feel like my shoulder is going to pop out when you do that. So that's what a positive apprehension test is. If they have pain but they don't feel like it's going to pop out, then I call that a apprehension test positive for pain only. But to me, it doesn't necessarily indicate instability. There's a cool maneuver you can do that if they say, oh yeah, my shoulder feels like it's going to pop out, don't go any further, doc. If you put your other hand in the front of their humeral head and gently push back with like 5 pounds of force, and then you try to really crank it, they'll be like, yeah, much better. So what you're trying to do is you're just literally trying to push the humeral head back and not allow it to slide forward, and they'll feel better. So whenever you do an apprehension test in the shoulder, you always want to comment on the relocation maneuver as well to verify that they are indeed having not just a sense of pain, but that sense of impending anxiety created by impending dislocation. Posterior shoulder instability, much less common. You will see it more in patients who have had seizures. The forces of the muscles towards the back and the back of the shoulder joint pull more than the shoulder muscles in the front, and therefore eccentrically it will pull more towards the back, and a shoulder dislocation in a patient who has a seizure is more likely to be a posterior dislocation than an anterior dislocation. And I've also seen it in pole vaulters, a person who has their arm out here and then hits the pole against the ground, and there's a big force backwards on their humeral head. You can also see it in linemen they talk about. Offensive linemen, they have their arms up and they get hit as they're trying to block for their quarterback or running back. So this is jerk test is kind of the unique test for shoulder instability in a posterior direction. And basically you kind of have the arm here and you push it and come across the body and it goes clunk. Because presumably in this position as you push back, the shoulder is subluxated posteriorly. And then as you bring the arm across, it reduces and there'll be a clunk. So that one's a little trickier to examine and get as positive. So now we'll go to some other joints. Shoulder we already did, working downstream elbow. Elbow dislocations are very common. If you work in an emergency room, you've probably seen your fair share of them. One of the most common joint dislocations we will see. Typically very amenable to a closed reduction in the ER with conscious sedation. As with many things in orthopedics, pull when the patient's relaxed, it'll usually help. And chronic elbow instability as a result of a elbow dislocation is quite uncommon though. So even though the dislocations of the elbow are common, the chronic instability is not very common. Hip dislocations, I'll say, are not uncommon, not super common, but not uncommon. And most often we hear about a posterior hip dislocation in a car accident because you're sitting, hips are flexed, you get in a car accident, dashboard hits your knee, and there's a posterior force directed through your femur, and you dislocate out the back. That being said, hip instability is very uncommon if you have your own joint in place still. So yes, you might have a posterior dislocation, you might have an anterior dislocation. Maybe there's some fractures associated with that. You get treated if you have fractures and you need surgery. But then to have chronic hip instability, it's very rare because the hip joint is a ball and socket. And unlike the shoulder, which is a ball on a plate, this is a ball in a socket. And that socket is usually a bowl that is like a hemisphere or close to a hemisphere. So that's inherently much more stable than a dish, right? Than a plate of the glenoid. So the exception to hip instability that is not as uncommon is when somebody's had a total hip. So anterior or posterior or lateral hip approaches, no matter which way you go in and do a total hip, you still have some risk of hip instability. And that is an exception to the rule about hip dislocations, or hip instability being an uncommon long-term problem. So artificial hips is a little bit different than native hips. Knee instability, you have to separate that into patellofemoral versus tibiofemoral. And I should even put on here, even though it's very rare, you could actually also add in there proximal fibula or proximal tib-fib joint. I've seen that a couple times in my career. So patellofemoral just means you have a patella that likes to dislocate, and that's very common in teenagers or in people under 30, and it's usually a lateral dislocation, and we'll go over that in a little bit. And then tibiofemoral is between what it says, tibia and femur. It could be the MCL, LCL, ACL, PCL, and we'll talk about this as well when we talk about the knee. And then proximal tib-fib, or the proximal fibula, it is held in place by strong ligaments. It doesn't actually create a joint that is in the true sense a weight-bearing joint, like the tibiofemoral or patellofemoral articulations. The proximal tib-fib joint, though, is still very important. There's a bunch of important ligaments attached to the proximal fibula. And so you don't want a fibula that is unstable floating around, and I have seen some unique cases of that. So didn't put it on here because it's so extremely rare. And then final, ankle instability, when you have it, and you say, my ankle always rolls, it tends to be unstable, it's usually due to repetitive and chronic injuries to your lateral ligaments at the ankle. So, and then we'll go to the next S. I think we're on the fourth one, strength. Strength is easy because you basically just go back to span, which we talked about in the beginning, range of motion, and you just test those same directions. So in the shoulder, we talked about testing for motion, how good is your forward elevation, how good is your abduction, external, internal rotation. Well, simply test strength, 1, 2, 3, 4, or 5 out of 5. In orthopedics, fortunately, we're usually dealing with 5 out of 5 or 4 out of 5 or 3 out of 5 at the worst. We're not into the big time neurologic details of, like spinal cord injuries or what a neurologist would test for. In the elbow, again, flexion, extension, pronation, supination. Hip, flexion, extension, adduction, abduction. Ankle, inversion, eversion. So inversion means the ankle goes down and in, which tests your posterior tibial tendon function. Eversion is up and out, which tests your peroneal tendon function. And then most other joints, like we talked about earlier, flexion, extension. So then we get to special. Special is things like the shoulder, Hawkins impingement test. So this means you bring your elbow out, you're at 90 degrees of forward elevation, and then the examiner passively internally rotates, and what you're doing is you're trying to pinch the bursa between the humeral head and the acromion. And I often will put my fingers there and I'll feel a crunch and the patient doesn't like it. So positive for pain, maybe crepitus. And so that indicates subacromial bursitis or impingement. Pain with cross-body adduction, so that's across your body and you're pushing on the distal clavicle around the AC joint, common for AC arthritis. So these are the unique things you have to learn based on what joint you're examining. Saw sign, bicipital tendonitis, or you can also have partial tears. You may recall biceps tendon too. One goes to the coracoid, and that's the short head of the biceps that almost never gives people trouble. The long head of the biceps, though, is more lateral, goes in a groove between the two attachment sites for your rotator cuff, and it's called the bicipital groove or intertubercular groove. And then the rest of the long head biceps goes into the joint and attaches to the superior glenoid. So it kind of does a down and then curves, and that killer turn is potentially a source of friction, partial tearing, sometimes even complete tearing. So the saw sign is, you tell people, do like a saw, but turn your hand up because that tests the biceps a little bit better. And as you're pulling, or they're pulling up, trying to make their elbow flex more, and you're going back and forth, they'll be irritated, and that can test for the proximal biceps pretty well. So saw sign, also speed sign. elbows out here straight and hands up, and you have the patient hold their arm up, and then you push down real quickly and tell them to resist you. That sometimes is indicative of superior labral and or biceps tendon pathology. Oh, by the way, all these tests are like a grade of D at the best, like 70% accurate. So just so you know, none of them are that great. O'Brien's test, to be honest with you, I can't even remember what it is. I quit testing it. Oh yeah, thanks, Sean. Thankfully, my PA remembers these things better than me. He puts all these positive exam findings. I'm like, yeah, I'm getting old. I don't remember them. So crossbody and thumb down, and then you push hard, and they try to resist you, and maybe positive for a slap tear. And then crank test, have the arm kind of in this mid-range position, and you're trying to push in on the humerus and then rotate. So you're trying to basically load the glenohumeral joint and grind it or crank on it, and potentially positive for glenohumeral arthritis, maybe labral tears. This one probably gets an F. This is probably like 52% accurate or so, sensitive and specific. So these aren't the best of tests. I wouldn't get too caught up in them. At the hip, there's femoroacetabular impingement, FAI. It's kind of the new thing about hip. We got tired of just treating hip arthritis. So somebody came up with new diagnoses and new problems and new ways to treat them, and arthroscopic hip surgery. And as you can see, I'm a little bit of a skeptic, but I do think it does exist, and there's a right patient population. It's just you need to be careful of how you select. So this is called the FADIR, F-A-D-I-R, flexion, adduction, hence the F-A-D, and then internal rotation, I-R. So FADIR, flex a little bit beyond 90, slight adduction, so you bring the knee across midline a little bit, and then you try to internally rotate. Pain and stiffness perhaps indicates that they have an osteophyte at their femoral head, neck, that's bumping into a torn labrum, anterolateral torn labrum, maybe. But then what do we do next? We get an MRI arthrogram. So, you know, we're not in a third world country, fortunately. We have the luxury of great healthcare and technology. So as much as we do all these things, and they're still really important, likely that the insurance company and the patient and everybody's going to say, well, let's get an MRI next of the hip. Then the sort of counterpart to a FADIR is a FABER, so flexion, abduction, abduction, and external rotation. This is usually flexion not quite as much, maybe in the 80-degree range, abduction, external rotation. So, and then you really push down on the medial knee. So you're standing like this, and you push here, and you're trying to pinch the SI joint. So, sorry, on the video, I just stepped out of the screen probably, but FABER. The other beauty is if you forget, you got your cell phone. Man, you all have it so good compared to when I started residency, and I was like, what is that thing? And then you have to go to a computer and do a search and can't find that article, and now it's just great. You just look up Faber test. So this potentially indicates SI joint pathology, so not the true hip joint. Trendelenburg lurch, if a patient has arthritis and it's a painful arthritis, or they have an abductor tendon tear, which can also occur in conjunction with arthritis or separate from arthritis. This is a unique gait that you should probably watch a video on. It'll probably do you better justice than me trying to describe it. But basically, if your hip abductors are working and your joint doesn't hurt, then if I stand on one leg, let's say this side is affected, my left side. If I stand on one leg, I can balance myself, and my pelvis will tilt just a little bit because my hip abductors are working, and it doesn't make sense for me to try to keep my pelvis level, because if I keep my pelvis level, my hip abductors have to do a lot more work. Does that make sense? So I just want to tilt just a little bit, like 2 inches over, so my center of mass of my body is in line with my leg. But if you have a painful joint or weakness of your hip abductors, you can't do that effectively. You can't rely on your hip abductors. So your hip goes out and you lean way over like this. So when you walk, the interesting thing is to make up for this, instead of walking and your shoulders and level, pelvis staying level, is you will lean over your side. And that helps your hip abductors not have to work as hard. Because if you lean way over, then your hip abductors don't have to pull to keep you up. Again, it's a little bit tricky. You see it on a video, it probably will make more sense. So when you have a person with a bad hip walking, again, let's say it's my left hip, they will walk like this and lean way over on that side. And they won't really do that on their other side because their other hip abductors presumably are working okay. Really out of luck if you have both hips affected. Makes for a very bad gait. Ober's test. So if you have trochanteric bursitis, hip abductor tendonitis problem, the IT band, if you recall from anatomy, starts up at your iliac crest. Big, thick band of white, thick tissue that goes all the way down the lateral thigh to the knee, to the lateral proximal tibia. And if you have a really tight IT band, then what are you doing? You're compressing your trochanteric bursa right against your bony structure of your greater trochanter. So if that is occurring, then you will have pain, potentially a higher chance of trochanteric bursitis, hip abductor tendonitis. So Ober's test, again, this is one that is hard for me to show you up here. You're basically trying to bring the leg forward and over, and it'll bother people, and they won't be able to bring their knee across midline as much. And so Ober's test is not perfect. Again, 60, 70% accurate probably. In the knee, my favorite joint, apprehension test, this is usually for the patella. Full extension of the knee, have the patient relax, and you try to translate the patella medially first, which usually never bothers anybody, and I try to gain their trust. And then I try to push it laterally, and they'll be like, oh, I don't like that. It's kind of like the apprehension test in the shoulder. They will feel like there's an impending sense of their kneecap dislocating. And again, it's not pain necessarily, it is a sense of anxiety more. There is no relocation maneuver for this one. Lockman test with about 20 degrees of knee flexion, and you try to stabilize the distal femur with one hand and then pull the proximal tibia forward with the other hand, and you'll see excessive translation in an anterior direction. And what we say it's not a good end point or no end point, meaning that if you have an intact ACL, you can maybe move the tibia 2 millimeters. And if you have a stretched out ACL but still attached, you can move it 4 to 5 millimeters, but it stops. There's like something that locks down. That's what we call an end point. But if you have a completely torn ACL and you have a pretty relaxed patient, you'll translate it at least 5 millimeters or more, and there won't be an end point at all. It'll feel like if you were asleep under anesthesia, I could pull this an inch forward. So that's what we talk about, no end point. Next, the McMurray's maneuver, classic in the knee for a positive meniscus problem. You can kind of load them varus, which loads the medial side, or valgus, which loads the lateral meniscus. So there's a varus and valgus McMurray's maneuver. Patellar grind test, if somebody has patellofemoral arthritis or just patellofemoral inflammation and pain. In full extension, you just literally push down on the patella, and as you're pushing down, you try to move it in a circle, and they don't like that. And you sometimes notice crepitus, and in general, compared to the other side. And then posterior drawer test, flex the knee 90 degrees, try to push on the tibia in a posterior direction. If the PCL is not working, then you'll see excessive translation. You can compare to the other side. So this is probably where you stand right now. It's a lot of information. This is a picture from my dad's farm. It's pretty amusing. He likes things like this. He said, hey, I saw something funny the other day. Look at this. But if you're confused, never fear. Like I said, there's plenty of, I'm sure, online review things that you can just go over. So just remember, 5 S's, and it'll serve you well, I think, for any orthopedic joint exam. So now we're going to shift gears and take about 20 minutes to talk about the knee. And I'm going to fly through some of these things because I don't want to take too much of your time and go beyond. But I put a lot of slides on here just in case I was able to get through them all. But if we don't get through them all, it's not the end of the world. And I'll, out of respect for the next speaker, I'll be outside at 2 o'clock rather than work into their time for their lecture. But I'll be outside for another 10 or 15 minutes if you have any questions. Happy to entertain them. The knee, as we talked about earlier, think about trauma versus atraumatic conditions. But even then, the next fork in the road is if it's trauma, think about the patient's age. Because if you're a teenager, you might injure your ligaments, your meniscus. But also patellar dislocations are going to be far more common in teenagers and people under 25 compared to over 25. And then also, if you're 15 and under for females, 18 and under for males, you can have growth plate injuries. That's something we don't have to worry about in adults. So you just have to think about age of patient, history, and go from there. Once you're a skeletally mature adult, ligament meniscus tears, some plateau fractures. And then once you get to be elderly, and this is a moving target, elderly will always be defined as my age plus one. So, so right now, I'm pretty safe. But actually, maybe I'll be safe forever with that definition, huh? Okay, so tibial plateau fractures, your ligaments and soft tissues retain their strength better than your bone, and everybody gets osteoporotic as you get older. And the tibial bone is more osteoporotic than the femur. So the femur is like the hammer that goes into the fragile tibia and causes plateau fractures. So any talk about the knee has to include patellofemoral problems because this is the number one thing that we see. Patellofemoral is by far the main sort of pain-generating potential site in a knee. And this is where, I could have so many patients not even worry about coming to see me if they just saw some YouTube video about patellofemoral pain before they consulted with an orthopedic surgeon because it's so common. So basically it's anterior knee pain in most cases because that's where your patella is. And it's worsened with squatting, stair climbing, lunges. So Sean, you can't answer this. What roughly is the multiplier for your pressure on your patellofemoral joint cartilage when you're squatting, doing deep, big time stair climbing, deep lunges? Is it twice body weight, 5 times body weight, 7 times body weight, or 15 times body weight? Any guesses? 7. 7 is probably the best answer. So if a patient's carrying a 20-pound box up a flight of stairs, that's 140 more pounds of pressure, not throughout the whole cycle of stair climbing, but at that moment when your knee is flexed maximally and you put pressure on that single leg, body weight times 7, or whatever you're carrying as well. So you can understand if a patient gains 50 pounds and they come to see me and say, God, I never had this problem since I gained 50 pounds and all the pain's here and it's worse with stairs. And sometimes I don't even have to examine them, although I do to make sure I don't miss something. But you kind of already know, ding, 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 I know why you're hurting. So it's often associated with crepitus. Remember we talked about crepitus earlier? Not really. I bet the crepitus was there before their pain even started though. So again, you can notice sometimes they come in complaining of left knee pain, but I notice crepitus on both knees and it's worse on the other side that doesn't hurt them. So again, it kind of gives credence to that thought that crepitus by itself is not major pathology. It can give us some clues, but don't focus on it too much. These patients usually don't have joint line tenderness, so that to me means potential meniscus problems or tibiofemoral problems. You can get an effusion, but it's not typically the case. More often it's just my knee feels a little swollen or tight, but a true effusion, meaning extra fluid in the actual joint, is not very common. And then the MRIs are often normal. But you know what? We get better technology. So now our MRI people know they have software that doesn't just look at the meniscus and the ligaments and the bone. Now we have software that looks at cartilage. So we can actually see that they aren't totally normal. Often, if there is some degree of cartilage damage at the patellofemoral joint, our radiologists are commenting on it pretty frequently. So it's but at least normal in the sense of no meniscus or ligament pathology that needs to be addressed surgically. So how do you treat this? It is not a surgical problem. Activity modification, obviously, quit doing 1,000 lunges a day. Formal physical therapy, it's not just your knee and your quads and strengthening and stretching, it's your hip abductors and your core strength. They've done great studies showing in physical therapy world that just focusing on the knee is not enough. You got to focus on the hip and the core as well. Anti-inflammatories, orthopedic surgeon's best friend, weight loss, occasionally steroid injections, just to kind of get people over the hump, allow them to work more aggressively with physical therapy. Try not to do cortisone injections every 4 months on like 2 years or 3 years worth. We try a couple maybe in these instances. And then PT focuses on the things we just talked about, and the best diagnostic tool, in my opinion, is a single leg squat test. So we already talked about the patellofemoral grind test as one of the special tests. But this is a really effective one. You just stand on one leg, usually their good leg first. I'll stand this way. And so you stand on your good leg, and you don't have to go very deep. You just say, go down 3 or 4 inches, do this 3 or 4 times. And I can feel it. I mean, I can feel right now more pressure at the front of my knee. And then you have them do it on the affected leg. And even if you have a meniscus tear or an ACL tear, you can usually do this if you don't have patellofemoral problems. You can still go down and up. But if the person has patellofemoral problems, they might not even want to do it. They may say, no way, it hurts too much. Or they'll go down and they'll be shaking like this, and they'll stumble and fall. And so I'll say, and they say, oh yeah, it really hurts. So for me, a single leg squat test is a great tool, because a lot of people will have meniscus tears and patellofemoral pain, both. And if I'm trying to figure out which is the number one pain generator, to me, that test is the one I rely on the most. So now, still talking about patella, but going to the patellar instability that we talked about, lateral patellar instability. So this is an axial image of an MRI. You can see the patella is sort of tracking off to the side. That's the lateral side. You can also see the bone edema, which is the white in the femur. So this person truly had a patellar dislocation. At one point, the patella was over, way lateral, and pushing on the femur, and that's why you had the bone edema in that corner. So what fails? The medial patellofemoral ligament fails, which you can sort of see on the medial patella. You see a black line. It's hard for me to point from here, but you see a black line, and then it just stops. And then there's nothing going to the femur. On the other side of the knee, you see a black line off the patella, and it's pretty well defined black line that goes, and it doesn't show it attaching to the femur on this image, but it does. So this shows that the lateral ligaments are fine, but if you dislocate your patella laterally, naturally, the medial ligaments are going to tear. And we sometimes treat these if there's, this is my 8th patellar dislocation. I'm having trouble playing soccer. Also, we do it in cases of extreme anatomy or if there's loose bodies. And here's an example of me. So if you're ever at a soccer game, football game, whatever, somebody dislocates their patella, you can be the hero. Get them to calm down. Their knee will be flexed, and you'll see the patella out lateral. Try your best to get them to relax. Tell them a funny joke, things like that. Get them to relax and get the knee extended, and the patella will often reduce on its own. But if it doesn't reduce on its own, as you're getting it close to full extension, just push it a little bit and push it from lateral to medial, and it'll pop, and they will be your best friend. This is a person who had a patellar dislocation and sheared off cartilage fragments, osteochondral fragments. Young person, like 16. Can't treat this arthroscopically. Only way to get the right angle is to open it up. You can see the defect in the cartilage. It's like the worst thing ever for a surgeon. I get sick in my stomach when I see cartilage problems like this. But we were able to piece together 2 of the main fragments with these little metal screws, and those metal screws get taken out later on once everything's healed. So you can deal with osteochondral fractures, sometimes fix them. Sometimes you have to consider medial patellofemoral ligament reconstruction. Other things, tibial tubercle osteotomy and trochleoplasty, don't worry about it. Just know that they exist out there. They're kind of complicated. Meniscus tears, a dime a dozen. We see them so often. There's so many types. Medial versus lateral. What direction? Are they causing catching, locking? Often pain with squatting and pivoting. So this is different than the patellofemoral pain we talked about earlier. These patients will often have an effusion, so meaning extra fluid in the knee joint. Joint line tenderness, again, medial or lateral, depending on where the tear is. And then that positive McMurray's, which is full flexion and then rotating the foot and trying to twist the knee, varus or valgus, depending on if you're trying to piss off the medial or the lateral meniscus. And the menisci are important to contain hoop stresses. So they're attached to the femur, the tibia, anterior and posterior, and then they're attached to the capsule around the rim. So when you put pressure, femur into tibia, if the meniscus is attached in all these locations, it's basically a sound washer, even though it's not a full circle, and it's not going to just splay out. If you have a meniscus root tear, which we're going to talk about in a second, and you put pressure, if it's not attached to the bone, the meniscus just splays out, and it's not doing anything. And it's sitting out south or east or west, I guess you should say. All kinds of tears. Posterior horn more common than anterior horn or body. Medial tears more common than lateral. And then you get those that are vertical, peripheral, associated with a recent trauma in a younger person. We can fix them. And then all the others that I put after that horizontal radial oblique complex, pretty rare that you can fix them. That's more of a trim. We see a lot of horizontal meniscus tears. These almost by definition are degenerative. A lot of times there's no trauma or minimal trauma. I was just getting up from a seated position. I felt a pop. And it drives me crazy because these people can open up an L&I claim and get it accepted. But who's to say that that pop didn't occur the night before when they were at home? So it's really, really fraught with difficulty. But if that's what the patient believes, and this is the way our system's built, even though I know it was probably just waiting to happen, I like it when I fell off a 4-foot ladder and twisted my knee and it was huge and swollen and I came to the ER that day. And then it's way more clear cut. But these are like, again, a lot of times there's not even an event. Like they just say, well, it started hurting about this month. And they're just like, you expect me to open an L&I claim on that? So we try not to operate on a lot of these, to be honest with you, unless they're causing catching, locking, and mechanical symptoms. So we are definitely more likely to operate in those situations of mechanical symptoms. We trim. You can see this big unstable torn piece of tissue. There's some fraying at the bottom. Orthopedic surgeons, I think, are hungry all the time because we describe this as crab meat appearance to the meniscus. And so it was removed because the potential for that to heal, if repaired, was very slim. It's a reliable surgery. It's pretty easy surgery to get through. The only thing I worry about is long-term implications. It's not because of the surgery, but because of the tear, and then the tear leads to tissue that's not functioning. And I elect to take it out in some cases if it makes sense. But to the patient, I say, this is not something I can fix. I can't put a new meniscus in or repair this. So you are going to have arthritis. I just don't know when. So post-meniscectomy arthritis. There are some unique tears. There's a bucket handle tear. And the bucket handle tear involves the inner rim of the meniscus tearing, but it's still attached at the anterior and posterior sites. And then the inner rim flips into the notch where it doesn't belong. So I tell people this is like the bucket handle where it should be on this side, and then it flips to the other side, and then it can't get back over. And these people will often have inability to fully extend their knee because there's this big meniscus trap. And it's a unique subset. And if we can get there in time, we can fix them. So when they're asleep and it can be, their knee can be twisted just the right way that I can push that torn bucket handle meniscus to the other side where it belongs, clean up the rim of tissue, make sure the tissue's healthy enough, and then do a repair with many sutures. And as you can see, there's some sutures in that meniscus. That's the body of the meniscus. And a little bit of the posterior horn you can see there too. All meniscus repairs are going to have a better chance of success if done in conjunction with an ACL. We don't know exactly why, but probably because they're occurring in younger patients who had an injury. That's one of the reasons. But also because drilling into the bones and stirring up a lot of bleeding is helpful to promote, you name it, growth factors, stem cells, I don't know exactly what it is, but it is good. And I joke around with patients, I'm going to fix your meniscus. If I don't do an ACL surgery and stir up that bleeding, I'm going to poke some holes in your femur and I'm going to create bleeding. And then it's going to create, hopefully, some stem cells in your knee joint that just know to migrate to your surgically repaired meniscus. And then I joke around and I say, so send yourself a bill for $8,000 for that stem cell treatment that you just did for yourself. There's a unique subset of meniscus tears called root tears. The x-ray on the left shows a knee when it presented with knee pain, and then 3 years later, after a root tear was diagnosed and the surgeon said they couldn't do anything about it, it was beyond hope. So now you see bone-on-bone medial arthritis. So a root tear, as we described earlier, is right close to where it attaches to the tibia. And if it's a full root tear, radial, meaning it goes from inner edge all the way to the rim, to the capsule, then that meniscus is essentially useless. Because now when you put pressure femur onto tibia, if the meniscus doesn't have that attachment point, it just splays out. And when it splays out, then there's too much cartilage pressure, and too much cartilage pressure after a couple of years leads to bone-on-bone arthritis. So we try to fix some of these. They're often degenerative. You can see some bone edema and subchondral fractures sometimes. And if it's a lateral root tear, it's more likely a traumatic thing in a younger patient. The medial root tears are the degenerative ones. And so here's the ghost sign on MRI where you see black meniscus, and then the next image it kind of gets fuzzy, and then the next image it's gone and it's all white. So there's the ghost because the meniscus is not there where it should be. And so the arthroscopic image shows me pointing to the stump. The little round thing is the stump. And there's a tear right next to it that totally disconnects. The middle arthroscopic picture shows after I've cleaned things up, and you can clearly see where the edge of meniscus is not connected to the bone anymore. And then the last one shows a couple sutures. We roughen up the bone, and we pull those sutures down into bone, and it docks it right into the tibia. And we hope that this works, because if it doesn't, they're doomed to get arthritis. But if it does, then perhaps I've given your knee 15 or 20 years more lifespan, and you don't need a knee replacement. But you do have to protect it. We're asking a little piece of tissue, like 8 millimeters in diameter, 8 to 10 millimeters in diameter, to heal to a little spot in the bone about the same size. So you've got to be really good about protected weight bearing. So you're thinking now, is anything good going to come out of this? Yeah, every once in a while you do get something good. Let's see. I'm going to skip ligament. I'm just going to show pictures now. ACL tears, the Lockman test we already talked about. You see a normal ACL on the left MRI image, the black structure in the center. You see kind of a torn, flattened. The angle is very low in terms of, more horizontal, and then no attachment on the femur. So that's an ACL tear. Yes, you can treat some of them non-operatively, but in this country, if you want to get back to aggressive sports, twisting, turning, pivoting, we typically will fix your meniscus, your ACL by rebuilding it. This lady had a chronic ACL tear. It was scarred into the PCL. So you can see a white structure that's kind of just stops, and it doesn't go all the way to the femur being on the right side of your first image. So now I've drilled a hole in the femur. I've got suture. I removed the ACL remnant. I've got a hole in the tibia you can't see, but that's where the suture dives into. And then we pull some tissue. In this case, it was hamstring graft into those two bone tunnels. The bone heals on both ends, and the ACL tissue in the center of the knee takes about a year to get strong, but we can get these people way better with a much more stable knee. Then you get multi-ligaments, and make sure you check for their motor and sensory function in their foot and ankle, as well as pulses, because there's a high chance of neurovascular injury when you have a true knee dislocation, not patellar dislocation, but knee joint, tibiofemoral. So here's an x-ray of that. Soccer player collided with another player, not good. Outside hospital, CT angiogram was done after a reduction showing no injury, neurologically fine. Knee brace sent to me. We did an ACL, PCL, MCL, and also fixed her meniscus. And about 2 years later, she got a D1 scholarship for basketball. Pretty proud of her. She did pretty amazing. This is more of a chronic thing. This person had multiple knee surgeries, came to me with multiple ACLs that had failed. And the reason is you have other ligaments that are torn. You got to address them as well. You can't just focus on the ACL and say, oh, your other ligaments will hopefully scar in. Doesn't happen. So he got an MCL, posterior medial corner, ACL revision, all kinds of stuff. So screws in all different directions, little metal devices to hold all these grafts down. It's fun stuff. So we're smoking hot now. I'll do this in just a few minutes, and then I'll leave some time for questions. So cartilage defects, like I told you earlier, any good knee surgeon who does sports kind of stuff gets sick to their stomach when they see big cartilage defects. This was a big cartilage defect on a person's lateral femoral condyle. So I go up to the top at their trochlea, the part that articulates with the patella, and for some reason I can create a cartilage defect, and it's surgically created, doesn't cause as much symptoms for some reason as the patient's problem. Probably because of the location. This is on the margin of the joint, the ones I created. The other lesion is literally right in the center. So every time the patient takes a step, he is loading that damaged cartilage. And then we do a transplant. So this is the snowman technique. 2 plugs stacked on top of each other. Gives you the coverage of that defect. And it went great. And he's very happy with his outcome. There are big ones like this. And bigger ones require bigger surgery, which in this case was an allograft, not autograft, which the last one was an autograft. And in fact, I had enough cartilage left over to do his medial trochlea as well. You can see the round one up top. I got the cartilage. It's sitting there from a fresh graft. I might as well. So anything I see, I've even done all 3 compartments. I had a guy who had a small lesion laterally too. So I've done all 3. It's the bioarthroplasty. So knee arthritis, knock-kneed or bow-legged. There's the medial side, the lateral side, the patellofemoral compartment. We got knee replacements as the ultimate option, although we try all kinds of stuff before knee replacements, including sometimes an osteotomy. So this kid had had a meniscectomy done with his ACL surgery on the right side, which is the left side of the screen, and developed bone-on-bone medial arthritis, was only about 35. Too young for a total knee, so I did an osteotomy. It's hard to convince people to have an osteotomy in this country because it takes a lot of time off work, takes a long time to heal, slow recovery. My buddy had a knee replacement and is walking the next day. This is very different. But in the long run, I think it's a good thing. Same patient. I didn't put any cartilage in there. Simply by cutting the tibia, realigning the leg, changing the angle and the biomechanics, you load the lateral side and you unload the medial side. And people have gone back in with MRIs and even arthroscopy and found fibrocartilage once unloaded. So the thought is that your body does have some regenerative capacity, not for real cartilage, not organized, not thick, but at least some type of fibrocartilage to fill that gap. And it doesn't get rid of all your pain, but if I can get you 80% less pain and a surgery that lasts you maybe 15 years until you're ready for a knee replacement, that's a good thing. So I like to be creative and think outside the box and not do a total knee on everybody. And that's what a total knee involves, and there's a lot of therapy involved, and this is what we never want to see with a total knee: a spacer system because of an infection, or a fracture above a total knee, which are no fun. And then, remember I told you if you wait, good things happen, and they grow up and they're potty trained, and you don't have to take car seats with you on vacation. It's amazing. I'm not the Sherpa anymore. Tibial plateau fractures, they're bad if you get them, and we can fix them, and they're simple. And then there's complicated. This guy's BMI was like 40, and he was trying to keep up with his 16-year-old son on a longboard, and he crashed. And he's sort of got a variant of a knee fracture dislocation. It's not good. That's his CT angiogram showing the popliteal artery and one of the fracture fragments. That's not good. So my finger was there about 10 days later trying to push that piece back in place and not have a popliteal artery injury. So he requires about 6 hours of my life and attention to detail and 3 approaches and plates and screws and all kinds of bone graft. And he's done really, really well, though. Has not gotten bad arthritis and didn't get an infection. And so we got fun stuff we can fix from time to time. So I'll conclude, again, say that good things come. This was about, I'm guessing 6 years ago, and that was about 2 weeks ago. Same spot, one of our favorite ones. Yeah, my son is now the tallest in the family. He is very proud of that distinction at the age of 14. So we have multiple offices. Renton is our main one here at Valley. We also have satellite offices in Covington, Lakeland Hills down in Auburn, Maple Valley. Have an urgent care here at Tukwila, right by South Center Mall. We try to do just about everything in orthopedics except tumor stuff and pediatric stuff. If it's like pediatric trauma, we do basics, but really complicated younger pediatric stuff we don't necessarily do. Got a great team of 14 surgeons, 20-ish PAs and nurse practitioners. If you have an interest in orthopedics, give us a call. Thanks much. Questions? Yes? So my take on injections is this, and this is what I tell every patient, and I try to draw things out and write them down because patients never remember, just like I never remember. My wife asked me, well, what did they say? And I go, I don't know. So injections, they all can help. Every single one that a person is willing to give you, there's probably some degree of benefit you can get from an injection. Granted, it'll be temporary. Cortisone is by far the one we use most because it's easy, it's cheap, don't have to ask anybody for authorization. We get it done right away. Next, probably on the list, actually not used very often, but is Toradol. So ketorolac can be used inside of a joint. Not FDA approved for that, I will admit, but we've been doing injections of Toradol into knee joints and into the soft tissues for years and not seen problems. It can probably help, maybe not as likely as cortisone, but it's another option for a diabetic whose blood sugars go off the charts when they get a cortisone shot. Or the cortisone shot only lasted me 2 months and I really need some pain relief, and then so sometimes I throw in there a Toradol or ketorolac injection. Hyaluronic acid injections, there's like 20 different brands. They all are based on this cartilage gel protein substance. And I tell patients probably works about as well as cortisone on average and maybe lasts a little bit longer. So hyaluronic acid injections, if an insurance company is willing to cover them, you can get them every 6 months. Cortisone is more like 3 to 4 months. But scientifically, head-to-head against cortisone, really no better, and absolutely does not make new cartilage grow. Cortisone doesn't do it, hyaluronic acid doesn't do it, PRP doesn't do it, stem cell injections don't do it. So no patient should ever believe that they're going to grow new cartilage with an injection. My big beef on stem cell injections is that without any clear evidence that it works better than anything else, why is it justified to charge $7,000, $8,000, $10,000 for a stem cell injection? Those docs can do 1 or 2 stem cell injections in a day and make more money than a surgeon gets doing 10 surgeries in a day. So, and without scientific evidence. So that's my big beef about stem cell injections. Hyaluronic acid injections, the other negative about it is that like 8 years ago, our academy, for some silly reason, decided to say that they cannot recommend for or against the use of hyaluronic acid injections. So they took a very neutral statement, neutral position. But in doing so, then a lot of insurance companies have latched onto that and said, well, if your own academy doesn't argue or state that it's beneficial, even though it was a neutral statement, then we're not paying for it. So increasingly, insurance companies will not pay for hyaluronic acid injections because they're expensive, upwards of $1,000 or more, as opposed to a cortisone shot, say $80, something like that. So I'm kind of neutral about it. I'm willing to try. There's good evidence that if you have a horrible knee, it's probably not going to help. But hey, I've got horrible knees in patients who are very unhealthy and elderly and don't want surgery or aren't good candidates for surgery. So to me, it's better than trying nothing. So maybe one more, and then I'll step outside to give the next speaker time.
So in primary care, sometimes you see people that have had a bad accident, and they've got a lot of hardware, and they're complaining of pain in the hardware.
Yeah.
And on the x-ray, you can't see any displacement.
Right.
How often, in your experience, does removing the hardware take their pain away?
A lot of it depends on the circumstances. Is there an open legal claim involved? Is it an L&I injury? There's so much other baggage with hardware removal. I usually tell patients, if we get about 2/3 of your pain better and you don't get a complication, let's all be grateful. And there are some instances when you can really feel it, and it's like bumping up against a tendon and they're irritated, that you feel like, okay, I got a 90% chance of getting this person better. But it is not always predictable how much pain benefit there is with hardware removal. It is a very mixed bag. And the best argument for me is if a person's had hardware in there 20 years and their pain started a year ago, and there's been no migration of hardware, no breakage of any screws, everything's exactly the same place as it was before their pain started, then I'm not going to get them better with hardware removal. So, again, I don't want to interfere with the next talk. Thanks for your time and attention. I'll be outside.